As we're all well aware, oxygen is essential for wound repair and angiogenesis. And although hyperbaric oxygen has been well established, certainly in the US and abroad and well researched, the data is indeed inconsistent. And the efficacy in healing chronic DFUs is really disputed now. This is evidenced by the recent failed Dutch Damocles HBO trial by Santima in 2018, recent systematic review for non-ischemic DFU in 2020 that said that based on the available evidence, the routine clinical use of this hyperbaric oxygen therapy cannot be recommended. It's not recommended by the ADA standards of care. It's not recommended in the NICE guidelines. And yet, in 2019, International Working Group guidelines gave HBOT, a weak recommendation, which was kind of surprising. And yet topical oxygen is, as I said, still controversial despite 50 years of use and more than 30 clinical reports and positive reviews in the medical literature. And much of the controversy was due to the lack of really robust data. But then we asked the question, is there evidence to support a biological effect of topically applied oxygen, of course? Unfortunately, there was a very poorly designed and executed trial by Leslie, published actually in Diabetes Care in 1988, that showed no effect. But that was such a horrible trial. I couldn't even imagine it being accepted for publication, even in a lower tier journal in this decade. Also, there are differing devices and differing delivery systems. And are they similar, or are there actually different effects? And we're talking about continuous diffusion or CDO devices versus pressurized devices, which we'll be talking about in this talk. And most studies are case reports or series of both DFUs as well as VLUs that generally provide positive clinical results versus the comparators in a variety of wounds. There was one negative CDO RCT in the past, which led opponents to say, yes, see, there's no evidence. But yet another CDO RCT showing efficacy in University of Texas 1A diabetic foot ulcers. This was published in 2018. And in 2020, we published our RCT on cyclically pressurized topical oxygen, specifically aimed at healing UT 1A to 2C diabetic foot ulcers. And there have been several animal studies that have demonstrated positive clinical, histological, and biochemical findings, which also support a definite wound healing signal for topical oxygen. And these are published by Fries in 2005, which we'll talk about further, and Sano, an unpublished series where he showed a definite effect of topical oxygen. So there have been several recent systematic reviews and meta-analyses on looking at this topic because of the interest in recent years. And the most recent one, recently accepted by Diabetic Medicine, this is by John Golage and colleagues out of Australia, and they looked at these 6 or so published topical oxygen trials, and they concluded that the meta-analysis suggested that topical oxygen therapy does indeed improve the likelihood of DFU healing. However, because not enough studies had looked at amputation cost effectiveness, the relationship was unclear. But this is consistent with other recent reviews, both from India as well as China, that indicate there is something to topical oxygen therapy. But yet the International Working Group discounted its value in favor of hyperbaric oxygen, which was, I think, a little bit short-sighted anyway. So what about animal studies? What about effects on the tissue? Now, this paper was really great. This is by Fries et al. And published in 2005, where they created wounds on the backs of pigs. And as we can see in the panel here, the left column are the control groups, and we'll look across the top row, staining for VEGF, vascular endothelial growth factor, at 7 days post wounding. And what we can see that there's a greater amount of staining here in the oxygen treated group compared to the control group, which was just room air. Then if we looked at smooth muscle actin at 16 days post wounding, we can see here that there's, on the oxygen treated side, there are definitely more formed blood vessels, indicative obviously of angiogenesis in the topically oxygen treated group. Looking at the wound site measurements at day 22, controls versus treated, we can see even after just 7 days of treatment at day 22, there's a significant increase in PO2 at the wound bed. And up here, hopefully we can see this, that when they looked at an implantable oxygen electrode implanted 2 millimeters into the wound bed, they were able to show that after just 4 minutes of time, the oxygen levels increased approximately fourfold, going from about lower than 10 millimeters of mercury up to 40 millimeters of mercury. And this is just in several minutes. So there definitely is a signal when applying a topical oxygen to a local wound bed. And I think this really is very convincing evidence that there certainly is a positive effect. So we took this further with our trial, which was published in Diabetes Care in 2020, as I said, and we looked in a very robust design with primary outcome of 100% healing at 12 weeks. And we found, compared to sham controls, and I think sham controls and I think intention to treat analysis must be done in all of our diabetic foot ulcer trials if they're going to have any robustness, if you will. We found that at 12 weeks, looking only at the ITT population, we found 41.7, about 42% of patients in the active group treated with cyclically pressurized topical oxygen healed completely, compared to 13.5% of the control group, which would really just receive room oxygen. And very interestingly and distinctly different in our trial, we also looked at secondary outcomes at healing at 12 months. Now, obviously the treatment was just for 12 weeks, and then we looked at 12-month outcomes. And we found that at 12 months, 56% of the oxygen-treated group were healed, compared to just 27% in the room air treated group. And of course, this was significant. So we saw a significant increase, not only at 12 weeks, but this carried through for a full 12 months. And as we can see, we did the adjusted odds ratio, adjusting for wound severity, UT grade, and we found a 6-fold increased likelihood of healing at 12 weeks with the oxygen group compared to the control group. Now, I think if we look at the Kaplan-Meier curves here, and this is for the primary outcome, where we can see a separation of curves for healing immediately starting at 1 week, and the green is the active group. We can see a distinct separation right from week 1. And again, our adjusted hazard ratio showed to be a 4.6. Almost 5-fold increased likelihood of healing. And this was also adjusted for UT grade, grade and scale. So there's definitely a signal here when we're looking at the cyclical pressurized topical wound oxygen therapy in healing diabetic foot ulcers. I don't think this can really be disputed at this point. So what about real world evidence? This was just a retrospective review of a large number of patients who have been treated with or without topical wound oxygen with this particular device. This was just a abstract and a poster presented at the recent diabetic limb salvage meeting in Washington, D.C. And what had been shown was that if we look up up here comparing patients who were never treated with topical oxygen, either adjunctively or alone, or no TWO2 versus the TWO2, the topical wound oxygen. There was an 88% decrease in hospitalizations, and there was a 71% reduction in amputations in those patients who had been treated with topical wound oxygen. Obviously, these were both significant. If we looked at the odds ratio, again, an 8-fold increased risk of hospitalization by not being treated, and almost a 5-fold risk of amputation for not being treated. And again, this was a retrospective real-world evidence review that corroborates pretty much what we had seen in our rigidly controlled and robust topical wound oxygen trial. So again, the data is quite consistent, where we are definitely seeing a wound healing signal and results at both 12 weeks and 12 months for managing these chronic diabetic foot ulcers. These were not acute wounds, these were chronic ulcers. And there certainly is a signal. So with cyclically pressurized topical wound oxygen therapy, the cyclical pressure pattern mimics the effect of sequential compression devices. This is more so for treating VLUs, and there is evidence to suggest a positive signal here for healing VLUs also. This was published by Topical in 2013. And this promotes venous return, activates the lymphatic system, and reduces edema, which also can be a component for DFUs. The higher pressure allows oxygen to diffuse through conventional compression dressings, Una boots for VLU therapies, and even can diffuse through total contact casts into the tissue bed. And most importantly, especially in this pandemic or post-pandemic world, this is an effective home-based therapy with proven clinical efficacy now for healing chronic DFUs. So we hope you found this data interesting. There will be more to come on this. We're in the process of developing a new systematic review and meta-analysis on this, and hopefully also within the next year produce a guidance document on the use of topical wound oxygen therapy. So with that, I want to say thank you very much.